We are going to introduce percutaneous K-wire reduction and cemented K-wire fixation for the treatment of distal radius fracture. This reduction technique is indicated when we predict difficulty in achieving good reduction, especially restoring radius high due to the fracture pattern, compression mechanism, tissue swelling, and so on. This 45-year-old male patient suffering a comminuted interarticular distal radius fracture. The patient is placed supine with the injured upper limb abducted. The operation is performed without tourniquet control. We initially try to improve the deformity to facilitate the word positioning. We palpate the radial artery and distal flexor radialis and inserted a 2.5 mm K-wire in between manually at the fracture level. We fill the fracture line by sliding the K-wire on the volar surface of distal radius. Then we advance the K-wire across the fracture side and insert it out of the dorsal skin. Care is taken not to injure the cephalic vein. A distractor force is gently applied on the two ends of the K-wire. The distraction force is oriented depending on the fracture patterns and the displacement, usually volarly with ulnar deviation. The fracture reduction is checked and CR fluoroscopy. If there is difficulty in reducing residual radial translation, we can reduce it using a joystick technique by inserting a second K-wire from the radial side of the radius. Alternatively, significant radial translation can be corrected by inserting a second K-wire over the ulnar side of the radius. The insertion point is often located at the radial side of the radial artery at the level of proximal fragment. The radial artery can be palpated easily. Then we apply a force on the proximal fragment of the radius radially through the second K-wire to correct the radial translation. The procedure is performed under axial distraction maneuver. The quality of reduction is checked and CR. If satisfactory reduction is achieved, we insert two 2.5 mm K-wires from the radial styloid process obliquely into the proximal fragment. Satisfactory reduction and wear position are confirmed and CR. Then we insert a third 2.5 mm K-wire from the radial side of the radius to the seminal notch, just beneath the articular surface of the distal radius. Finally, we insert a fourth 2.5 mm K-wire transversely into the proximal fragment of the radius to prevent postoperative radius and ulnar translation and the rotation of the distal fragment. We bend all wear end toward the fracture side and mount bone cement to secure all wing ends together. That cemented K-wire frame is created to maintain the reduction, the radius high, and prevent wear migration. Satisfactory reduction is confirmed and CR. A conventional external fixator can be added depending on the fracture pattern, bone quality, and the surgeon's preference.